So good morning, ladies and gentlemen. My name is Jens Chapman. I welcome you to our grand rounds today. Today's topic pertains to a disorder which afflicts millions of Americans. It has ended throwing athletes' careers, and again, as we're sitting here, probably about a quarter of the audience has had symptoms of compressive neuropathies, such as carpal tunnel syndrome or elbow problems. We are very fortunate to have an outstanding group of upper extremity physicians and surgeons who are very insightful in these problems and who will tackle this today. Without much further ado, I'll ask one of our finest residents, Dr. Ghatan, to take the lead and show us a survey of this problem and introduce us to our faculty. So, Andrew, good morning.
Thank you. Thank you. Thank you all for coming this morning. Grand Rounds is entitled Compressive Neuropathies, Watch and Worry or Decompress and Hope. I'd like to introduce myself. My name is Andrew Ghatan. As Dr. Chapman mentioned, I'm a fifth-year resident in the Department of Orthopedic Surgery. I'm pleased to present Dr. Douglas Hanel, Professor of Orthopedics in the department, Dr. Jerry Huang, Assistant Professor, also in the Department of Orthopedics, and Dr. Standaert, a Clinical Assistant Professor in the Department of Rehabilitation Medicine. These are our disclosures. The idea for today's talk was that patient who has had a compressive neuropathy release and presents to our practice with symptoms that haven't gotten better. There's some kind of failure in their management. How do we think through these problems and what do we do about them? So to investigate that, I'm going to begin by giving a review of the epidemiology and pathoanatomy of compressive neuropathies. I'll present two cases that suggest this problem, and then Dr. Hanel will go on to discuss one of them, the recalcitrant cubital tunnel syndrome case, followed by Dr. Huang, who will talk about recalcitrant carpal tunnel. Dr. Standaert will teach us a little bit about the use of electrodiagnostics in these complicated cases. So just to begin, compressive neuropathy is simply the neurologic dysfunction that occurs as a result of compression on a peripheral nerve. And in medicine, there are many examples of this, and you can peruse this list at your leisure. But the two that I want to draw your attention to are carpal tunnel syndrome and cubital tunnel syndrome. This problem matters because it's common. Millions of patients annually will suffer from these conditions, and there are associated high costs with them. The pathophysiology can be complex with multiple overlapping etiologies. And of course, that can lead to diagnostic dilemmas as we try to sort through exactly what is affecting the patient. And as usually the case, diagnostic dilemma will lead to a therapeutic dilemma as we try to figure out what to do for that patient. So let's begin with cubital tunnel syndrome. This is simply compression of the ulnar nerve within the cubital tunnel at the medial elbow. A patient may complain of ulnar paresthesias, aching pain in the hand and arm, and perhaps intrinsic weakness or wasting in severe cases. Diagnosis is typically made by a combination of physical exam, history, and electrodiagnostic studies. Just briefly here, there's a figure of the elbow. I want to draw your attention to the cubital tunnel. The ulnar nerve can have multiple sites of compression of the arm, but the cubital tunnel in particular is bounded on one side by the bony anatomy of the humerus and on the other side by the aponeurotic roof of Osborn's fascia. Cubital tunnel syndrome has an incidence that's not quite well understood. There was a study out of Italy that showed that 15 to 30 cases per 100,000 person years. We know that it's more common in men than women, but overall it's not very well studied in that regard. Carpal tunnel syndrome, on the other hand, is very well studied. This is compression of the median nerve within the carpal tunnel at the wrist. Symptoms can include paresthesias in the median distribution of the hand. Symptoms are characteristically worse at night and may awaken patients from sleep. There can be thenar wasting or a loss of grip, strength, or dexterity. And as previously, the diagnosis is made by a combination of history, exam, and neurodiagnostics. Many risk factors have been associated with carpal tunnel syndrome, including female gender, elevated BMI, diabetes, certain occupational risk factors such as repetitive wrist motion. Pregnancy has been associated. Patients with inflammatory arthritis can have synovitis within the carpal tunnel, and that can compress the nerve. And interesting, of course, also that some have suggested the morphology of your hand and wrist, the shape of your anatomy, can affect the space available for the median nerve. And there was one study that showed that those with a shorter hand from the tip of the middle finger to the proximal wrist crease, those with a wider hand, had a higher incidence of carpal tunnel syndrome. The epidemiology, based on multiple studies, puts the figures at between 88 to about 300 cases per 100,000 person years in men, and about 190 to 540 cases among women. This is a problem that's more common among women and is far more common in the US population than in Europe. And if you think back to the previous slide, our populations differ in regards to those risk factors. That may explain the differences we see there. The U.S. Department of Labor and Statistics keeps very close watch on carpal tunnel syndrome in particular because of how common this problem is. In 2010, there were over 22,000 cases of at least one day of work missed due to this diagnosis. And in fact, this equaled almost 1% of all cases of at least one day of work missed for a non-fatal injury. Between 1999 and 2010, carpal tunnel syndrome was either first or second in rank for days of work missed among U.S. workers. And here's a figure based on that data. As you can see, second only to fractures was carpal tunnel at 27 days, median number of days missed. So of course, this becomes a costly problem. It's estimated that each claim is about $30,000 in direct medical costs, times that figure gives us $680 million in direct medical costs annually from this one problem alone. So there's a huge incentive to get the diagnosis right, to treat it right the first time, to prevent this from drawing out. To make the best case of that, we want to understand simply why does compression cause neuropathy? And this has been interesting to investigators for decades. In the 1930s, the prevailing theory was that of ischemic paralysis. Basically, Lewis was one of the pioneers in this. He did studies with human volunteers applying pneumatic cuffs to the upper arm. And by inflating them serially, he said that the disturbances are due to lost blood supply and not to pressure alone. He felt that because a different segment of the nerve was being compressed and the symptoms didn't change, the only way to explain this was perfusion. And though his particular studies have been discounted more recently, there has been good studies lately that have confirmed that there is an ischemic component to compressive neuropathy. A study done in rat tibial nerve showed that even at low pressures, as little as 20 millimeters of mercury, there's a collapse of the epineurial venules. And as you increase that up to 80 millimeters of mercury, there's complete ischemia within the nerve. In direct competition with this theory is the pioneering work of Ochoa in the United Kingdom in the 1970s. He believed that there were structural changes that occurred within nerves that were independent of perfusion. And he did this in baboon legs. He would apply a tourniquet to their leg at 1,000 millimeters of mercury for 1 hour, so very high pressure. But what he found were predictable and reproducible structural changes in the nerve. And what is perhaps most interesting is that these changes were not distributed evenly under the cuff. He found them to be clustered at the edges of the cuff. And he believed that there was something about the differential between the compressed and the non-compressed areas that created shear forces that actually structurally damaged these nerves. And though he was doing these experiments at what we would consider superphysiological pressures, Dike in the 1980s repeated this study using very low pressure, 50 millimeters of mercury, for 2 minutes, and confirmed that these changes were occurring even at that low exposure. Here's a figure from Ochoa's work. I'll draw your attention first to the top. You can see that what we see here are two adjacent myelin sheaths. One myelin sheath has been pushed and are invaginated into the next. And if you zoom in closer, not only do you see a disruption of that node, but there's actually a disruption of the axoplasm, so damage to the nerve fiber itself as a result of this compression. Around that same time, Upton and McComas made a very astute observation within their own clinical practice. They looked at 115 of their patients in whom there was an EMG-confirmed carpal or cubital tunnel syndrome, and they made the observation that 70% of those patients also had cervical spondylolysis. And so they generated this hypothesis that perhaps compression at one site, for example in the cervical spine, would predispose a nerve to impaired function with compression at a second site, say the cubital tunnel or the carpal tunnel. I want to just speak briefly about the anatomy of a nerve, just to get us all up to speed here. So, when we talk about a nerve fiber is a nerve cell, and this is the basic unit of the nerve. And these nerve fibers are wrapped with the endoneurium. Several nerve fibers are bundled together by a perineurium, and the perineurium is key in forming what we call the blood-nerve barrier. And the reason that blood-nerve barrier is important is because outside of the perineurium, there are these larger, relatively large epineurial vessels. And these vessels are somewhat leaky. They feed the nerve and provide it the nutrition, the oxygen it needs to be viable. Well, the conditions that the nerve fibers are bathed in need to be very tightly controlled because there's electrical conduction going on. So the perineurium maintains that space by tight junctions between their cells to maintain a tight environment that allows the nerves to function appropriately. And what we find is that with chronic compression, the first thing that fails is the blood-nerve barrier. And that sets off a cascade of changes within the nerve, including endoneurial edema, perineural thickening, increased intraneural pressure, which some have likened as a miniature compartment syndrome of the nerve, and then going on down through further structural destruction of the nerve up to Wallerian degeneration. So let's return to the dilemma that I presented at the beginning. Compressive neuropathy is often not attributable to a single lesion. There can be multiple overlapping causes. decompression can fail for multiple reasons. And recovery of the nerve can be slow and depends on reversal of structural changes. So a patient who may have had a successful decompression may return to us with continued symptoms simply because not enough time has passed for the recovery of the nerve. So of course, and again, always, how do we integrate history, exam, and diagnostic testing to provide a plan for the patient? I want to speak very briefly also on this question of success versus failure in treating compressive neuropathies. I think we can all recognize what success would be, which would be the resolution of symptoms. But I would suggest that failure is not so clear, not so linear. There can be a failure because of recurrent symptoms, such as a patient who had a successful relief of their symptoms, who then returns 6 or 9 or 12 months later with a return of their symptoms. This typically can be explained due to scarring around the nerve. And it's very different from a patient who presents with persistent symptoms, say someone who had a release and never quite got better. This would be, for example, if someone had an incomplete release of their carpal tunnel. And lastly, there's a third category, patients who have new symptoms after surgery. And this is when we worry about an iatrogenic injury, which was sustained at the time of decompression. So clearly, these patients are all failures in the sense that they've had a surgery and they still have symptoms, but they failed for different reasons. And we need to be able to understand that and to think about these problems in this way in order to provide the best plan as far as working them up and coming up with a plan for their further treatment. So a 60-year-old female whose chief complaint is 10 years of right hand and arm pain and numbness. She's had partial relief with the use of a cock-up wrist brace. She has diabetes and has peripheral neuropathy from that condition. She's a non-smoker. In 2000, she had an open release of a right carpal tunnel with incomplete relief of symptoms, and on the left side had a similar procedure with complete relief. When she presents to us, her exam shows positive Durkin's carpal compression test and a positive Hanel sign. And complicating things further, she also complained of neck pain, had a positive Sperling maneuver on exam. Her electrodiagnostics were much more suggestive of an issue with a motor latency of 6 milliseconds and non-recordable sensory signals and denervation of her abductor pollicis brevis. So now I'm going to turn the floor over to Dr. Hanel, who will be speaking further on management of recalcitrant cubital tunnel syndrome.
Well, thank you, Andrew. There's 3 scenarios that happen. You have persistent symptoms, you have recurrent symptoms, and then you have recurrent but worse symptoms. Now, if you divide that and you look at that in the examination of the case that we had, in our particular case, a standard level of monofilament sensibility, which is a great standard for measuring compressive neuropathies, monofilament sensibilities. Now, normal is 0.07 grams in the upper extremity, the great majority of patients. And in this particular patient, he has 0.2. It's not really changed. In this particular case, patient, he had no particular atrophy. His key pinch was equal bilaterally, but he is subjectively weaker. There is no particular provocative maneuvers that would be attributed to his cubital tunnel syndrome, this particular maneuver, which is not helpful, unfortunately. And we look at the electrodiagnostic studies that were sent for us, and you look at those, and I'm going to ask Dr. Standaert to discuss those. So when you have and you face this patient, you've got to ask 2 questions. And the 2 questions are, what caused this? And how do we treat this? And unfortunately, the diagnosis is a challenge. And the treatment is a challenge. And your best friend, the literature, which I believe in, and I think that we ought to know, isn't going to help you much. So one of these people is the patient, one of these people is the physician as this comes into your practice. Because most of these people come to my practice with a scar, and that's not my scar. It's been operated on by somebody else. This patient hasn't gotten better, and the question is always why. Now, having been faced by that, a much better article and a review of the literature was done by Sammy Sun, representing this fellowship last year, and it appears in the Journal of Hand Surgery. And he went through the literature, and he allowed me to author it with him, allowing me to edit his findings. But probably the most important thing, and I can synopsis it in the following fashion. Usually, there's scenario number 1, no clinical improvement after surgery. And the most common cause for that in the literature is that the wrong diagnosis was made. And this was alluded to by Andrew when he said that 70 to 80% of these patients also had a cervical radiculopathy. Or there was no clinical improvement because the patient had a really bad nerve to begin with. And in our case, that wasn't true. The patient had a pretty good nerve by examination, but he still has symptoms and he still has pain. So Maybe it was an inadequate ulnar nerve decompression, so we'll put that there. Boom. The second scenario, and the scenario that we often see, is I was better for a while and then I got over it. And in that case, the patient did well for a while and then seemed to have recurrence of symptoms. And there's just a recurrence of the scar and the compression in the site of the surgery. And I think that's probably the most common cause in my practice. And then the third is the iatrogenius, which is a neologism for the brilliant surgeon who is his own worst enemy. And a great example of that is in Sue McKenna at Washington University in St. Louis, looked at all of her recurrent or recalcitrant carpal cubital tunnel syndrome, and she found that 65% of those patients, the cause of their pain had nothing to do with the nerve that had been compressed, but a cutaneous nerve that had been injured at the time of exposure, and the neuromas associated with them, 65%. You know, the diagnostics in these particular settings are difficult, and I'm going to leave that to Chris to talk to us. But the one thing that is important about electrodiagnostic studies is not so much the looking for the cause of the compression of the ulnar nerve, but looking for the other things and making sure that you're not dealing with a radiculopathy or upper motor neuron disease or Guillain-Barré or something like that. The dilemma in a lot of these patients is that, or certainly in my practice, is that they come with some sort of other issues. You know, is this a labor and industry issue? Is this workman's comp? Okay, are the insurance carriers asking you to come in and to provide? And there's people that are saying, well, we did the operation, that's it, you're done, there's nothing that we can do for you. So you have to build that relationship with your patients as you are treating them, and you have to get a sense for what's going on with that particular patient. Is there a non-operative management of these patients? And I believe that there is. We all fall asleep like this, and we all curl up in a fetal position, which puts great compression on a nerve. And in this particular setting, when they do that, we will use non-operative methods, as in sleeping, having people sleep with splints that keep them from flexing their elbows while they sleep, and having night symptoms and night compression. We work on desensitization of neuromas as helpful. If we go to the literature and take it one step further, the problem that we have is if I wanted guidelines, there's no prospective clinical trials. The numbers would have to be huge to get significant numbers. But most of the care that we receive and that we direct stating and looking at the literature is based on small case series. You know, here's 30 cases. And this is done from the Mayo Clinic, and it's the source of this particular illustration. But in that particular illustration, they said that the most common cause of multiple sites was inadequate release of the medial side of the medial intermuscular septum. The point being is that there's a failure of decompression in this particular area of the multiple areas that can be there. They proposed that the revisions for this particular surgery in this particular setting, if you believe that this patient is indeed symptomatic, is to take and to do three things. Either do a submuscular transposition, which they did in 24 cases, a subcutaneous transposition, which they did in 5, or an intermuscular technique, which they did in 1. And they found that having done that, having just said we're just going to fillet this particular arm open over a long distance and find all those compression points, 75% had good or excellent results. And that there was unsatisfactory results, but the unsatisfactory results were in those patients that had just a subcutaneous or an intramuscular transposition. So the point being is that this is a surgical procedure that has been, that more and more, it has been popularized as being one that can be treated by small incisions in small areas with small endoscopic procedures. And in those particular cases, when it fails, the out to that is to go and to do broad exposure, broad releases. And you know, as you look at that and you look at the series, we have one system that says submuscular transposition is the only way to go. And so we have 18. Now we've got up to 50 patients that the authors say that the way to manage these patients is to do a submuscular transposition, which is a very large operation and has the morbidity, not mortality, morbidity, of having a large operation, a large incision. But we do know that in those particular settings, chosen appropriately, the patients do improve in the great majority of those. But it's also interesting that in looking at all of these series, even though patients say that they improve, if you actually do objective measure of their grip strengths and pinch strengths, only 5 out of their 18 patients actually had an improvement in grip or pinch strength. So there are 10 small series of 5, 6, 7 cases or more where a site of compression was identified, released, and in those particular cases, they all had submuscular transposition. So the literature would say, again, over and over again, that submuscular transposition has got to be the way to go until you get to the next series. Here we have 20 patients, and they all got subcutaneous transpositions, and they all, or the great majority of them, did well, with the exception of patients who were older than 55 and who had significant neuropathy going into the case. So if they had significant electrodiagnostic or physical findings, they did not significantly improve. Now what happens if we just go after this one series, and this is Dr. McQueen's series. You look at 100 revisions, 73% of them had this neuroma related to the surgical incision, 74 had the neuromas excised or placed in a viable muscle. And in this particular series, unfortunately, the conclusion is people got better. But if you read the fine print, they don't tell you how many people got better and how better they got. And so I don't know how many of those returned to work. And so you're faced with that. So what about adjunctive therapy? You'll hear about this, especially in the press and in your literature, especially in the advertisement section, where people will do neurolysis and then something else, and they'll wrap the nerve with veins, or they'll wrap it with a triceps wrap or something. And again, if you look at that, these are small case series, usually authored and championed by one particular author. And we have pain improvement in the patients. 2-point discrimination, improving slightly. We've used graph jacket. We, meaning the literature, has used graph jacket in a small number of series, apparently successful in 3 of those 5 patients. I think that people jump on that. I see patients in my practice who have been referred to me who have had these procedures done, but if you really look back at our literature, it's based on series, large series, this large, the size of my hand, which is really kind of frightening if we think about what we're doing to these particular patients. So in this particular patient, I got a complete history, complete examination. I used my electrodiagnostic studies to confirm that I didn't have a diagnosis. And I was comfortable that this patient was truly somebody who really was trying to do better with his life and was truly interested in going back to doing what he was doing, which was being a steel worker. So I was comfortable with that patient. So in this particular setting, I identified all the cutaneous neuromas that I could find. I avoided tourniquets for the reasons that Andrew implied. We can do this surgery. We can expose this extremity without having to use a tourniquet and to put an insult to the injury, adding a tourniquet to the injury. So we use broad incisions. We raise appropriate flaps. We find neuromas. We find the ulnar nerve proximally and distally and free it of all of its scar. And we go back to this illustration and we look at each one of these points and just go down this checklist. Did I get the arcadophrostia? Did I get the medial intermuscular septum? Was Osborne's ligament completely released? Was the medial epicondyle or any osteophytes that were present and they're moved aside? Did I address those? Was cubital tunnel addressed? And we took those. And intraoperatively, it looks like this. This is a broad incision. This is the ulnar nerve. And as you'll see, it goes from here all the way into the mid-forearm. And this is a large incision for this particular problem. And I recognize that. We then elevate the flexor pronator mass off the medial epicondyle. And we're going to transpose, or I'm going to transpose the nerve anteriorly. And when I do that, I want that to be a straight line. There are no kinks. This nerve takes a straight course across the arm and the antecubital fossa into the forearm. We go distally in dividing the flexor carpi ulnaris, both heads, and the origin of the flexor muscles as it enters into the forearm, as shown here. These are the step cuts that are used you're going to take and elevate the flexor pronator mass along the lines that are shown here, and at the end, and when we close it, we take blue line and attach it to yellow line, essentially lengthening the tendons. Postoperative treatment is a long arm splint. The elbow's at 90. Forearm pronation, forearm wrist are in neutral. Week 3 to 6, we go to range of motion and strengthening. And in the end, based on this very limited series, well, hopefully the results are as good or better than the literature. So thank you.
We're going to have Dr. Huang come up and present his management of recalcitrant carpal tunnel syndrome. Thanks, Dr. Huang.
So I thank Andrew for inviting me to be part of this session and his wonderful introduction. So as Dr. Ghatan mentioned, compressive neuropathy is very, very common and carries incredible cost to society as well as healthcare. Even today, carpal tunnel release remains the most common hand procedure performed in the United States. Your typical patient comes in with pain and numbness, nocturnal awakening. They're waking up in the middle of the night, shaking their hands because of pain or numbness or tingling, clumsiness, difficulty holding objects, dropping objects. They're having trouble buttoning their shirts, putting on jewelry. We know that the majority of carpal tunnel releases are very effective, but symptomatic relief is only seen in 70 to 90% of patients. So the question is, which patients are failing and how do we do the adequate workup, and what's the approach to a patient that undergoes a fairly simple, straightforward procedure, yet at the end of it does not have complete relief. So what are some of the contributing factors? You could blame the surgeon, perhaps. A wrong diagnosis. So somebody who may have a more proximal compression, it may be cervical radiculopathy where you have stenosis more in the cervical spine, or compression of the median nerve more proximally. So you may either have a proximal compression or the phenomenon is double crush. So you have both compression proximally and at the carpal tunnel. This may be polyneuropathy, somebody with diabetes, or perhaps other musculoskeletal complaints. So the pain is not so much for carpal tunnel, it may be from trigger finger, maybe from osteoarthritis. Again, incorrect diagnosis can lead to a patient that's not happy or satisfied because their symptoms never went away. And the second scenario where you have a patient with persistent carpal tunnel, perhaps more commonly, is an incomplete release. If you have very poor visualization, could be either with endoscopic release or limited open, where you're really not visualizing the most distal aspect of the carpal tunnel. This is the example of a patient who had a revision carpal tunnel release. You can see from the figure there that the distal portion of the transverse carpal ligament was completely intact. So incomplete release leading to persistent symptoms. You could also have the opposite problem where the release was done adequately distally, but proximally over the distal antecubital fascia or the distal forearm fascia. It was never quite released. Again, you have persistent symptoms leading to incomplete release. So what if the surgeon did a really good release, is confident that he had a complete release? And there be another cause of the persistent pain or numbness. It's really important to do a really good exam, a motor examination, particularly looking at C5, C6 nerve roots, looking for perhaps a cervical etiology for the pain and numbness. Sensory examination, if you look at somebody coming in with numbness over the thumb and the index finger, if it's purely volar, likely secondary to carpal tunnel or median nerve compression. If you have volar and dorsal, looking at median and radial nerve, perhaps this is more of a C6 nerve root problem. Numbness or pain that's more proximal in the lateral forearm and arm, again, looking at cervical etiology. EMG findings, you may find EMG findings over the cervical paraspinal muscles, again, indicative of perhaps cervical pathology. So if you do a carpal tunnel release, symptoms are still there. I do a shout out to my colleague, Dr. Mike Lee. You may consider getting MRI of the C-spine to look for possible pathology more proximally or up in the cervical spine, and perhaps referral to your spine colleague. If you have an exam consistent with proximal compression, again, not very common, but you can have compression of the median nerve more proximally to the forearm, might want to do a provocative maneuver, perhaps a corticosteroid injection to see if you get transient relief. And there may be cases where it's indicated to go ahead and proceed with a decompression more proximally. Patient disease. You may have done everything you possibly can. The correct diagnosis, complete release, everything was done accurately. This is simply something that's been going on for too long. Chronic nerve compression, irreversible nerve damage. This is a patient likely the nocturnal symptoms will be better. Even though it's severe disease, you have denervation, axonal loss, nocturnal symptoms are typically better. The pain, typically most patients will have some pain relief. The numbness persists. The weakness, that muscle atrophy may never go away, but they do have partial relief. So this is something that perhaps there's nothing you could really do, and it's something that may be expected in somebody with severe carpal tunnel syndrome. You also have to look for perhaps other ulterior motives, psychologic, perhaps workers' comp patients who just simply won't get better. Looking at scenario number 2, recurrent carpal tunnel. They had either complete or incomplete relief of the symptoms, only to find out a few months later, a few years later, the symptoms came right back. As Dr. Hanel alluded to, most of these cases you see significant scarring or fibrosis of the nerve fibers, perhaps adhesions of the actual nerve to the surrounding soft tissue, whether it's the skin or flexor retinaculum, or tenosynovitis. Flexor tenosynovitis involving the flexor tendons leading to, again, a decrease in space within the carpal tunnel. A study by Helsizer in 1998 looked at recurrent and revision carpal tunnel and found out you really can't tell the difference oftentimes between scarring and perhaps incomplete release. So you can't really tell, did the initial surgeon now do a complete release, or is it simply scarring that occurred over time? He did find that when you go back and do the surgery, revision surgery on somebody who had a prior endoscopic carpal tunnel release, relief was expected in 77% of patients versus 47%, which may point to the fact that a lot of these patients maybe had an incomplete release. Endoscopic, maybe the release was incomplete, and upon complete release, the majority of patients did quite well. And not surprisingly, relief was seen in 18% of workers' comp patients compared to 84% of those patients with commercial insurance. More recent series by Jones out of UC Irvine found symptomatic relief that was partial or complete in 90% of patients with open versus 76% with endoscopic prior to the revision surgery, with complete relief expected in approximately 50% of patients. His series of 50 patients, 18 of them had recurrent symptoms, meaning that it got better and came back. 32 had persistent symptoms that never went away. And he found out in the group with 32 persistent symptoms, incomplete release was seen distally in 18, and proximal incomplete release seen in 14, so almost 50-50 split as far as the incomplete release. So it's really important to obtain a careful history. You really want to separate between persistent and recurrent carpal tunnel syndrome to really figure out the next steps in diagnosis and treatment. Examination will other causes of pain and numbness, whether it's cervical radiculopathy. Perhaps the numbness is not really over the median nerve distribution, but more ulnar over the ring and small fingers. Again, pain, oftentimes you have a patient presenting to you either from a primary care referral or themselves thinking that pain in the hand is carpal tunnel. You really want to rule other causes. It could be trigger finger or flexor tenosynovitis that's leading to pain distally rather than carpal tunnel. Physical examination includes sensibility testing, prerogative maneuvers, and also nerve conduction study in EMG. Especially somebody coming in with recurrent carpal tunnel, it's important to obtain, if you can, the preoperative EMG prior to release, prior to initial surgery, and there's one done afterwards. Oftentimes, Dr. Standaert, hopefully will touch on this a little bit too, you could have somebody with a complete release, but electrodiagnostic studies still show persistent latency and changes, and it's really important to compare preoperatively and postoperatively EMG, and perhaps a new one to compare the initial results, initial latency. Corticosteroid injections in my practice very useful. Somebody come in with recurrent carpal tunnel. If they have a relief from the cortisone injection, a study in 2012 found that 87% of these patients can be expected to have a symptomatic relief from their revision surgery. So they do very well. So the cortisone injection works with the decreased inflammation, decreased swelling. With the revision carpal tunnel release, for the most part, they do quite well. If you combine numbness with the provocative maneuvers, with a positive result from a cortisone injection, they have 100% sensitivity as far as, or a positive predictive factor in terms of predicting a successful surgery. If you have no relief of symptoms from a cortisone injection, only 60% of patients did well. Positive nerve conduction study with EMG findings. If you had a prior EMG, preoperative EMG, and your latency is actually higher than the preoperative EMG from the first surgery, this is a patient that likely had an incomplete release and would benefit from a revision carpal tunnel release. No prior EMG, I think it's helpful to perform a cortisone injection if you have complete relief for 1 to 2 months. This is a patient that likely would do quite well with revision carpal tunnel release. If you have no relief, it's really important to look for other findings, whether it's cervical pathology or other sources of pain and numbness. As far as surgical technique, for the most part, somebody coming in with recurrent carpal tunnel symptoms have a fair amount of fibrosis and scarring. It's an extended carpal tunnel release, extended incision, where you're starting from Kaplan's line and going proximal to wrist flexion crease. You want to do a very complete external neurolysis, a separation of the scarring from the flexor retinaculum. And several authors, including Dr. McKinnon from WashU and Dr. Jones, are really proponents of doing a fairly complete neurolysis, internal neurolysis, where you're separating the fascicles with microsurgical instrumentation, make sure you don't have residual fibrosis causing compression. In those cases where we have quite a bit of scarring with circumferential fibrosis, where it's quite a bit of work to separate out the fibers, as well as hyperesthesia over the wrist, several authors have recommended an interposition flap. This could be biologic, where you're putting a muscle flap directly over the median nerve, hypothenar fat, synovial flap, or perhaps a synthetic flap. Some of the synthetic flaps Dr. Hanel alluded to, a graft jacket, and a couple different wraps have been described out there that may be of benefit to prevent scar and create an interface between the skin, the retinaculum, and the median nerve. So the third category, their scenario, is new symptoms. Somebody who undergoes release, symptoms are actually worse, or symptoms that were not there prior to surgery. You really have to look for iatrogenic injury. Was there an injury to the actual median nerve, the palmar cutaneous branch, the recurrent motor, perhaps the common digital to the middle and ring finger, again, a very, very common branch that's injured as part of your carpal tunnel release, or as part of your distal release, you might have injured the superficial palmar arch. So the location of the incision is very important. If you look at the original surgery, the incision is very, very radial. You really want to be careful and cognizant of perhaps injury to the palmar cutaneous branch of the median nerve or recurrent motor. You have decreased sensation, especially over the thenar eminence. Again, possible injury to the palmar cutaneous. And especially endoscopic release, a injury to the nerve to their web space or the common digital to the middle and ring finger is actually not uncommon. It's the nerve that's the most superficial, the most anterior. As you're deploying your endoscopic blade, there actually is a fairly high risk of injury to that nerve if you're not careful. This is actually an interesting study for the residents in the audience, done in Northwestern, one of our future fellows. They actually polled the residents, asked them to look up in textbooks, internet, and draw how they would do a carpal tunnel release. See a pretty wide spectrum of surgical incisions, some very radial, some very ulnar, some very proximal, some very distal, and there's actually one that was dorsal. So based on that examination, somebody coming in with recurrent or persistent symptoms might be a good predictor and give you some insight into what might have happened. So somebody with new symptoms, severe hyperesthesia over the site of injury, it's important, I think helpful to perform a Hanel 2 to 3 inches proximal to the injury. And oftentimes you'll have a response directly into the affected distribution. Sensibility testing with moving and static 2-point and threshold monofilament testing. Another scenario where you may have an iatrogenic injury that's simply neuropraxia, so will get better with time. Somebody with endoscopic release. So imagine a very tight carpal tunnel with the instrumentation going into the canal with the median nerve and the flexor tendons. If you're doing repeated passes over time with swelling as the surgery is going on and now, you can actually cause neuropraxia with simply just blunt injury to the median nerve. So it's not uncommon with endoscopic, especially one that takes longer, that you may have persistent symptoms. So in summary, carpal tunnel surgery, correct diagnosis, done well, very effective with symptomatic relief. It's important to obtain a correct diagnosis and a careful history and physical if you have the 3 scenarios: persistent, recurrent, or new carpal tunnel symptoms. Thank you.
Hi, I'm Chris Standaert. I am a physiatrist, so a non-surgeon. A significant part of my practice is electrodiagnosis, management of peripheral nerve injury, extremity things. Do a fair amount of spine care also. I'd like to thank Andrew for asking me to be here. I'm honored to be on the panel with the other speakers. And my job is really to give you a brief explanation as to the role of electrodiagnosis in compression neuropathies and how this can help you. What does it show? What does it really help you with? In general, I frequently use the term EMG as well. What we're really talking about is electrodiagnostic studies or electrodiagnosis, which encompasses a number of different types of studies and techniques. So actual needle EMG, which we'll talk about, nerve conduction studies, SSEPs, motor evoked potentials, all of these are different mechanisms to look at the physiologic function of the nervous system. They try to give you some objective evidence as to how the nervous system is functioning. And when we're talking about compression neuropathies, we're looking at the peripheral nervous system in particular. So in compression neuropathies, I think the parts of electrodiagnosis we really do and we're interested in are the needle EMG and the nerve conduction studies. EMG is done with a needle electrode, to find about a 27 gauge needle you put into various muscles, and you look at sort of the electrical activity within the muscle. And you're trying to look at several things, particularly in this setting, you're after evidence of axon loss. And when you do this, you can tell several different things. You can see evidence of denervation. You can often break that out into whether that's acute or chronic, which can help you to some degree. So that tells you roughly, weeks to months versus a year or more. That's sort of our acute versus chronic. We can't tell 4 versus 6 months. That's a little too fine. But 3 months versus a year or two, we should be able to give you some information on if it's there. You can also look at motor unit remodeling. This occurs over time as people get collateral sprouting into previously denervated muscle fibers. That takes on the order of months to start to show up. Over years, that will sort of, again, morph and change and progress. And again, we can often tell sort of subacute versus chronic injury by looking at that. We can also look at motor unit recruitment. When you have a dropout of some axons in a peripheral nerve, the remaining axons can fire at a higher frequency than they can normally. And you can pick up some evidence of denervation that way. Nerve conduction studies is the other half of our study. And this is really, typically we use recording electrodes on the skin. Occasionally we'll stick an intramuscular electrode in to record. And we can look at both sensory and motor function separately. The parameters we look at typically are conduction velocity, which is how fast the nerve is conducting. Normal conduction velocity in the upper extremity is about 50 to 70 meters per second. We use a term called distal latency, which is roughly equivalent to conduction velocity, but that's the time from stimulation to recording from the distal recording site. And in a sensory study, that really is conduction velocity. In a motor study, that actually includes transmission through the neuromuscular junction. That's why we separate it out as a different number than purely velocity. Some of the parameters we look at that can help us, the amplitude of the response, how big a response do we get, both for motor and sensory studies, that is somewhat related to the number of axons that are present. And we can get some evidence, again, of axon loss. Axon loss results in slowing. When we do nerve conduction studies, we're really picking up the fastest conducting fibers. So when you lose some of those, they drop out, the velocity will slow. And we can, again, get evidence of amplitude reduction, which helps with axon loss. And particularly for these compression neuropathies, it's demyelination we're looking for. And that results in focal slowing on a nerve conduction study. And that is, as Andrew correctly pointed out, that's the dominant pathology you see in compression neuropathies. In an idealized world, this is something like you would see with a focal compression neuropathy, so at the elbow. So what you have is a recording electrode from the hand and the ulnar innervated muscles. You have stimulation at the wrist and stimulation up above the elbow. And if you stimulate the wrist, you get a nice robust response, which is that response on the left from the muscle. And if you go up above the elbow, you should get the same response. If there's something impairing the conduction through, especially the myelin, what you'll see is you'll get a drop in amplitude or a complete absence of a response when you stimulate proximal to the area of compression. And if you can sort of shorten these segments over which you study, you can start to narrow this down a bit. This shows a big, broad segment to the whole form, but you can narrow this down. And you can get to within about 8 centimeters of distance and still stay fairly accurate in terms of your velocities. But that's what the kind of thing you're looking for. Electrodiagnosis can help you with a number of different things. The things we can find when we do this. We can find a diffuse disorder, so peripheral neuropathy in particular. And when we define a peripheral neuropathy, we can often sort it out as to whether it's an axonal or demyelinating neuropathy or mixed, or a sensory or motor neuropathy or mixed, which really helps us in sort of, again, narrowing down our differential diagnosis and what the problem is. So if you really sort of break down the pathophysiology, you can sort this out. We can also identify multifocal disorders, so like a mononeuritis multiplex, which you'd see in like a vasculitis or a Parsonage-Turner brachial neuritis type disorder. When we're looking for things like we're talking about today, compression neuropathy, we're looking for a focal peripheral nerve process. And in an ideal world, when you really can find all the things you need to find in an electrodiagnostic study and you do it well, you can often sort out radiculopathy versus plexopathy versus a focal peripheral nerve problem. And as has been pointed out by multiple speakers, that's often the issue here with recalcitrant problems. What is the problem? Was it really the right diagnosis in the first place? Is there something else going on? So all these things have distinct patterns of abnormalities on our testing. So doing all this stuff, where is the benefit in electrodiagnostic testing? It helps you with several things. It really shows pathophysiology of injury. So as we'll talk about, it doesn't show sort of diagnosis necessarily. It tells you what the pathophysiology of the nerve is when there's a nerve problem present. It tells you something about the extent of the injury. How bad is it? That's a useful thing to know sometimes. So you can some idea of how bad the pathology is. You can get some idea of the duration, how long this problem has been going on, and what the biological adaptation to this problem has been, which can be very helpful. And you can often tell the location where the problem is, which obviously is a useful thing from your perspective. And to some degree, again, as has been pointed out, you can use the studies to give you some ideas to the potential for recovery, which again, a helpful thing. So when you need these pieces of information, this is a very useful study. Although helpful, there definitely are limitations to electrodiagnostic studies. I mean, it identifies nerve injury. Something has to be wrong. The typical teaching is to get abnormalities on a needle EMG exam, you have to have lost about 20% of the axons. So you're talking a fairly significant injury here. Things like pain, transient ischemia, other things we don't really find. The EMG, the nerve conduction, the whole study, I'm using the terms myself, the whole study doesn't diagnose pain or a cause of pain. It diagnoses nerve injury, nerve pathology. So when you have other issues, like we pointed out again, prior surgery without baseline studies, this is tricky. So when you do a carpal tunnel release, often the nerve study, the conduction studies will improve, but don't typically normalize, or don't always necessarily normalize. So when you do a study on somebody who's had a prior carpal tunnel release, the studies very often will be abnormal. And if you don't have a baseline somewhere, it's very hard to tell if that is just persisting problems with the nerve or persisting delays, even though there's improvement, or whether you have a new or continued problem. When you have multiple peripheral nerve disorders, it gets tricky as well, because things get very patchy. You have to put them in these little boxes and patterns as to where the problems are coming from. And not every nerve is accessible. I have a lot more ways to look at an ulnar nerve than I do a long thoracic nerve. Although I can look at the latter, I'm more limited in what I can do to do so. This is somewhat of an operator-dependent test in terms of how you set the test up and how you interpret it. And you will find this occasionally, that people don't always agree on how they interpret or do a study. That's where it really does help to actually know and work with your electromyographer so they understand how you think and what you're looking for. And there's a bit of the phenomenon that if you don't know what you're looking for, it's hard to find it. The people you're working with have to know what it is you're looking for, as do you. So I'll use CT as a bit of an example to describe sort of how we do this, or some of the numbers we have in utility. For looking at carpal tunnel syndrome, there are multiple different types of testing that have been described in the literature. They all tend to be comparative studies between median nerve function and ulnar radial nerve function, usually within the same hand. Some go side to side. But there are numerous different things described, and if you go around the country, you'll see a whole different pattern of different studies people do to find this. I think some of the things that are important to consider when you're looking at this is carpal tunnel syndrome is a syndrome. The word syndrome has a distinct meaning. A syndrome is a diagnosis based on a combination of symptoms and clinical signs and findings. And so when you do a nerve conduction study, we're not finding a syndrome. We're looking at neurologic function, essentially. So when you do these, not all patients with carpal tunnel syndrome will have abnormal electrodiagnostic studies. You can have the entire syndrome without necessarily having the abnormalities on the test. Similarly, you can have abnormalities on the test, yet not have all the things that go along with the syndrome. You'll see asymptomatic people have abnormalities in their median nerve. And do they have carpal tunnel syndrome? Probably not, as most of us would define it. You have to keep that in mind. When looking at all electrodiagnostic testing, our sensitivity and specificity are somewhat limited. As I pointed out, it has to be a pretty significant injury to find it. Some of our trouble with sort of calculating these comes down to a gold standard. What is the gold standard for saying somebody has carpal tunnel syndrome? How do you define it? As the little drawings of where you would operate on it are, I don't think we would all define it the same way either. So that makes it very tricky when you start looking at numbers. In this particular institution, what you very often see in terms of our diagnostic approach to carpal tunnel syndrome is a reference to the Cumulative Sensory Index. This was developed by Larry Robinson, who was our former chair. And really what it is a combination of multiple sensory comparisons in the same hand. So it's a combination of the differences between the median radial studies to the thumb, median ulnar to the ring finger, and little sort of what are called transpalmar studies. Short studies of the median ulnar mixed nerves across the wrist. And what you do is you combine the latency differences for all those different studies into one number. And they found this is actually a fairly good diagnostic test. When the cumulative number is 1 or greater, you have a sensitivity of about 83% and specificity of 95%. You hit 1.2, it goes higher. Sensitivity goes down slightly, specificity goes up. It's a useful test, but this is often you'll see in our institution of CSI. So if it's 1 or greater, that's indicative of a problem with the median nerve at the wrist. That's how we typically look at it. The CSI is helpful. It does correlate with surgical outcomes to a degree. Dr. Malati, who's one of our residents, did a study here looking at this. They looked at 272 patients retrospectively and looked at their CSIs and their surgical outcomes to see what happens. And the people who had a CSI of 2.5 to 4.6, which is not subtle, that's fairly prominent findings of median nerve problems on your nerve conduction studies. Had the best outcomes in terms of pain or paresthesia, about 71% symptom relief. Interestingly, people who had a lower CSI, but still 1 or greater, and people who had a really high CSI had the same rate of complete symptom relief, which is about 50%. They actually had 6 people who had normal electrodiagnostic studies who also had 50% relief at surgery. So although it can help you, again, the whole thing doesn't necessarily totally correlate with the clinical picture. There are lots of other things that influence the syndrome and all the symptoms you have. If you look at limb symptoms in general, and so when you do these things, when do you do these studies, what are you looking for, how useful are they? There are several studies of people looking at patients who came in with various symptoms going for electrodiagnostic testing. A study by Haig is interesting from '99. They had 255 patients consecutively referred for study for upper extremity symptoms. And they tried to look at how often they really just sort of confirmed the referring diagnosis and how often they found something that was different that really changed the approach to the patient. And really, in 42% of their patients, the testing altered the diagnosis. It gave information that changed the way people thought about the problem. And 37% of people that confirmed it, no clarification in 21. This may be influenced some by selection, that when people aren't totally sure what the diagnosis is, they're probably more inclined to send for studies. So that may influence this. It may not be a totally random sample. But you often will change how you think about it when you do the test. If you're looking at when things are going to be positive, if you have abnormalities on physical exam, so overt weakness, numbness sort of things, you're more likely to have an abnormal EMG, but a decent number of people who have pretty normal exams still will have abnormalities on their studies. So given all of this, how does electrodiagnosis actually help you? It can help you with several things. One, is there a focal problem? We can often identify this. Again, compressive neuropathies, this is the whole question. Is there a focal problem? If there is, where is it? Can we narrow that down to at least a small area for you within a few millimeters, within a few centimeters, perhaps, if we're lucky? How bad is it? So is it a bad neurologic problem or not so bad? Will it get better? Is there some potential for getting better? Is it getting better or worse? You can watch these over time and see if they're changing. And is there anything else going on? Do you really know the full scope of what the neurologic issues are? So in your setting, when would you need this type of information? I didn't talk much about the ulnar nerve, but numbness and tingling in the small finger, there's a long differential diagnosis for that. The ulnar nerve can be compressed at multiple places. You can have a lower trunk plexus problem. You can have a C8 or T1 problem. All of these can do this, and electrodiagnosis can often sort this whole process out. When you have an unreliable or inconsistent exam, is somebody weak or not weak, and 2 different people examine, they get different exams, the whole thing isn't adding up really well. It can help you because it gives you objective evidence of function. If you have confounding medical problems, a diabetic, somebody who has another neuropathy, another cause of neurologic dysfunction, and you're trying to sort out, is there some acute or superimposed focal problem on this, it can be very helpful. When you have discordant or uncommon neurologic findings, it can help you. I did one a few weeks ago for one of my partners, for somebody who had a C6 radiculopathy, but the dominant presentation of his radiculopathy was scapular winging. That was the most prominent physical abnormality, which is unusual for C6 radiculopathy, but that is what it looked like he had. People with prior surgery, it can help because, again, they don't electrophysiologically always become normal. They don't clinically always become normal neurologically after surgery. So persisting neurologic things, you can, again, sort out that acute versus chronic issue. And really, when you need to know how the peripheral nervous system is functioning is when the test is helpful for you. So to conclude, electrodiagnosis really provides information on the physiologic functioning of the peripheral nervous system in this setting. So it can tell you there's a median neuropathy. It can't tell you there's carpal tunnel syndrome, but it gives you some objective evidence of how things are working. It can be helpful in identifying multiple aspects of the pathophysiology of the peripheral nervous system, which can help you in terms of how you think about the patient's problem. And really, you should use it when you want evidence as to the presence or absence of specific neurologic issues. It can help you sort these things out. That's all. Thank you.